We're back on the recording, everybody. Good afternoon, good afternoon. I'm going to finish up a little bit of respiratory just because I need to do the pulmonary function studies. And because I think it's an important part. I used to do them here in the lab. We did them on Monday in my advanced phys lab, and I got some pretty good tracings. So I just loaded them here rather than bring all that get up here. And then we'll go into the world of digestive. At the end, if anybody's interested, and you're under no obligation, that is I love this. They call an assembly of the lung and the sheep lung and sheep heart in one of these. Are you ready for sheep pluck? You gotta have fun. Where's the pluck? So if you want, I can take it out and give it this all compressed now. But you can feel cartilage here. The lump in there is the heart. Kind of get an idea of the membrane or something. Now we can open it up and we can squeeze away. So I just put that out in case you're interested in doing that at the end. Once I get done going over what I think we should get over today. There's not a ton. Let me take a look. This is my favorite part of the whole thing. And somebody reached out to me about, no, maybe not from this lab. What I'll probably do is I will send you, and I'll get it together, maybe sometime over this week, a take-home quiz to do. Don't start, the two of you. It's just not fun. So, your hair's different. Yeah, I like it. It's, do not tell my wife if she comes in here that I noticed your hair being different. How do I look? You're like the guy. You're like, sure, working with your hair, eyes, new outfit, new makeup. You're like, It's like, help me. But that kind of a thing. So I'll probably send you which so then Miss Kinsey's conspicuous by her absence. Yeah. I heard that one before. I'm sure she'll be here. Nevertheless, so I'll probably send you a take-home quiz, and I'll put it on whenever it's due. I reviewed the calendar. I'm fond of doing now because the song says we're getting very near the end. Okay. So 1, 2, 3. It looks like we only have four more labs to get together here. Okay, to finish what we have to do after today. So that's not a heck of a lot, I don't think. So it's today, the 29th, the 5th, the 12th, and the 19th, and we're done. The 19th would be the final, which will be sort of constituted similarly to what we did with the other final, except it will have, I think we just have a certain number of labeling things that we'll do on that particular day. Yes, you can bring the reference material sheet. We'll leave it at that. We don't like to use the word with the CH. I see, my kind of person. Are we good with that? We have very limited attention today. No, it's got to be on. Yeah, I could get a complex over this, but I won't. I mean, if I had me for class, I wouldn't come to class. And maybe I'd come occasionally. So let us begin. This is the respiratory part of the program. You probably had all this lecture-wise. Very briefly to summarize, okay? And this is, I don't do the pressures and stuff. Effectively, it's a negative pressure. Everything is designed so in such a way that there's always a small amount of negative pressure within the lung cavity itself. okay, without getting into the physics behind it. Or effectively, all you're doing, everything is related to one thing and one thing only, and it's the ideal gas law. All those laws that they have names, which I hope they don't ask you in lecture, but they might. Boyle's law and this law and that law, right? That type of stuff. They're all related to the ideal gas law. And all that says is that pressure and volume maintain a relationship that's based on some universal constants and ambient temperature. PV equals nRT, N and R constants. The T is the temperature. As it goes up, those measures would go up proportionally, but they're inversely proportional. In a closed space, if the pressure goes up, okay, the volume would go down, and vice versa. Volume goes up, the pressure. So what do we do in the lungs to breathe? We expand our chest cavity. We increase the volume, therefore the pressure has to diminish. And that allows, it's a subtle change, but enough of a change to draw air in. Once the air gets through, and you remember from last time, this is important, the conducting system, where we move air in and out by those pressure changes, once it gets into the exchange area at the respiratory bronchioles that open into all those alveoli, simple diffusion takes over, and we rely on the gradients between oxygen in the lung and oxygen in the blood, and the other way around, carbon dioxide in the blood and carbon dioxide in the lung itself. And so they go in opposite directions. What's interesting about that, and they should have hit this in lecture, I hope they did, is they're not by any means, those gradients aren't equal. There's a lot more oxygen in the lungs than there is in the blood. There's only a small amount more carbon dioxide. But the reason they exchange equally is carbon dioxide is considerably more soluble in the membrane. Carbon dioxide gets through that membrane a whole lot easier than oxygen. So those are some of the factors. That's the one thing I would remember. So I'm not going to do any of these pressures and stuff like that. What's interesting that some of you, particularly in nursing, may very well face is what happens if there's a problem. And what happens if there's a problem is this: a lung can collapse. It could be anything from a plugged bronchiole, but more often than not, it's something traumatic. Before we had airbags, we used to see a lot of it with steering wheels impacting, and obviously sharp force trauma. When it's sharp force, could be a knife or a bullet or something along those lines. Anything that violates those linings allows air to rush in. It's such a delicate balance that when the air rushes in, it alters the pressure, hence the name tension. Pneumo, P-N-E-U-M-O, means basically an opening into the lung, and thorax is self-explanatory. And what happens, that lung that's affected collapses. The trouble with collapsed lungs, there's always a little negative pressure in the lung that keeps the lung expanded. And what really helps with that process, even if it starts to compress, is the surfactant we talked about from type 2 cells. That keeps the lubrication up, that even if the cells are delicately touching, they can re-expand. When it collapses all the way, the surfactant loses its efficacy. It doesn't work terribly well. And it's much more difficult, the longer it's like that, to reinflate the lung. That's why we're in a very big hurry to reinflate the lung. What we use in an emergency room is called a chest tube. So basically, you insert something here, you suck out the air mechanically, allow the lung to re-expand, and gradually advance or pull that out as it heals until such time as the lining heals and you can do without it. Residents in hospitals love that when you're in an emergency room. We don't want to take pleasure out of someone else's pain, but they love passing chest tubes. I hate to say it that way. You want to learn as much as you can, and unfortunately, bad injuries you learn a lot from. And so they're always interested in doing those things. It's not, I didn't take a great deal of pleasure out of anybody suffering, but we understand that that's part of the learning process in medicine. So inhaling and exhaling, the only part that expends energy normally is inhaling, and it's a small amount. You have enough energy to flatten your diaphragm, that expands the thoracic cavity, and enough to motivate the external intercostal muscles to also expand. That increases the volume, pressure fall. All you do is relax them, and the elasticity takes over, and you exhale. Only if you're taking a deep breath or forcing out a deep breath, like to blow out the candles, should that require extra energy? And here's these laws. But, okay, and they go through this whole thing with all this here. And if you did that in lecture, fine. I go through it as well. I don't go crazy about it. So we look at what happens during each breath. So you can see that when we look at how much air is moved between inhaling and exhaling, going from the bottom to the top, that's got a fancy name. It's called a tidal volume. You sitting there, different with me talking, is you're not even noticing you're breathing, and you're moving about a half a liter of air. That's an important measure when it comes to evaluating lung function. And that's what we're getting to with regard to this. Other things that are non-involved in respiration, okay, that can change it. Coughing, sneezing, hiccups, that type of stuff. What's it related to? Resistance, anything blocking the airway or limiting its opening. That surface tension nugget again. And this, lung compliance. When something is compliant in a biological sense, one word suffices: stretchy. So we go back to, where do you have children and they want to have a birthday party and you have to get balloons and you have to blow some of them up and you don't have the helium thing with you. What do you do first with the balloon? You stretch it, right? Everybody remembers that? Also useful for balloon puppets. That's physics. We don't do physics. And where the resistance is, there's in the medium-sized bronchi, it's a function of how many branches and the total width. Roughly the medium-sized bronchi is where most of the resistance. After that, unless there's something obstructing the passageway, there's not a lot of resistance, because as it branches, you get more and more total surface area. So the air normally shouldn't have a lot of trouble moving. Okay? And so when something is constricted or blocked, it can be very significant. That's when we see the EpiPen. Most of the time we see that in severe allergic responses, severe asthma, or anaphylactic shock. Something you probably dealt with. Did you guys cover that in immune? Anaphylactic shock? Don't even start. Don't even start, girl. Somebody with a nut allergy. Everybody knows somebody who carries an EpiPen, right? For bee stings or nut allergies. They have a disproportionate amount of IgE, something you should have gotten, immunoglobulin E, attached to what are called mast cells in the respiratory tree. And when they release, the histamine and the other substances that are released collapse those bronchioles. It can't intubate somebody. The blockage is in here. It's down in here. The only way to reverse that is with an agent that you should have learned about in the autonomic nervous system. If you had me, you did, like epinephrine or a bronchodilator like Ventolin. The epinephrine works faster. That's why we use the EpiPen first. Then the other stuff comes along. So surface tension, again, is surfactant as long as it's present. Problem, premature babies or other unusual conditions that are there. The most common type we see surfactant, infant respiratory distress syndrome. For those of you who might have an interest in going into neonatal, that's where that becomes a significant issue that are there. We now make surfactant artificially, and we can extract it naturally, which has improved survival rates of premature neonates significantly. My middle one, who is going to be 39 in May, when he was born about 4 weeks premature, fortunately did not have the respiratory problems that were associated with his. He had the best way to say it was ABO incompatibility. And what that means is that he had some antibodies that were problematic. Was not erythroblastosis fetalis. And so, and you see that with a lot of kids, they come out somewhat jaundiced, and they use ultraviolet light to get rid of the excessive amount of bilirubin that's present. So he underwent that and some other stuff too. That was there. And that's what they're talking about. And the lung compliance is stretchy, distensibility, whatever you want to call it. So that's important. And then they look at all that. And anything decreases it over time. Infections, pneumonia, severe respiratory. I'm sure COVID would have done that to people. When people get pneumonia, oftentimes they leave fibrotic issues, areas that will scar. Okay, and that can be a problem down the road. Breathing is effortless. When someone has difficulty breathing for whatever reason, it is exhausting. Even when you see these folks, and you see them all the time, whether in the grocery store or out with oxygen, they're having a hard time breathing. It's exhausting, just the very act. They could be in a wheelchair or riding in a cart because you're expending it. And energy is energy. You don't have to expend it physically in the sense of walking or running or lifting or doing some physical activity or going to work out. I mean, whenever you're doing something that expends more energy than you should, it's tiring. And people aren't necessarily as sensitive about those types of things. We used to see that with dialysis patients. It takes a lot out of you. Push that blood into a machine and get it back in. They're sitting in a chair for 4 hours. Why are they tired? Well, it's the procedure. Okay. So and this is how we look at so things that unfortunately add to this. Some folks, deformities of the thoracic area. As you get older, those costal cartilages over there become ossified somewhat. So they begin to get more bony, and therefore you don't have that degree of compliance and intercostal muscle paralysis. So it's a lot harder for people, particularly with that kind of aging, to be able to breathe. Which brings us to what I wanted to stress a little bit in this early part of today before I introduce digestive. And digestive is my favorite unit because I have an existential relationship with food, as you may know. I eat, therefore I am. So, did you do this? Capacities and volumes? No, you're looking at me with negative in your eyes. You guys do it with Dr. Robbins? You're all not giving. Did you do respiratory yet? Okay. We'll do it here. I love this. For most of you, it's absolutely inconsequential. You're all healthy, I'm guessing. Okay? None of you have smoked for 40 years like I did? Probably not. I don't think anybody's 40 here. You have to smoke from the time you were born. So how do we ascertain? Where is its usage for young, healthy individuals like you in sport? This is conditioning that's been used in endurance sports, particularly cycling, like Tour de France type cycling, and a lot of other sports to develop, particularly for endurance, long distance running to improve lung capabilities. What are we going to talk about? Long-term chronic respiratory diseases. Read that as COPD, chronic obstructive pulmonary disease, and emphysema, which very often overlap. It's based on this. We have certain volumes, and when we add volumes together, I told you about one, tidal volume. How much comes in and out, just like the tide, is where it gets its name. And so we measure them. In the old days, we used the electronic device. But I got one of these when I came here, started teaching here 15 years ago. One of these, you fill it with water, and then you have a tube that you can blow into, and you displace the water, and you can measure it on that scale. And they work, and they're kind of fun to use, but they're a little messy and they're heavy. And I even took, when we had the gym down here, like that building down there, I don't know what they're using it for down there, whatever the name of it was. That was before they built the North Athletic Center. That was the gym. I used to carry it down there, and we do experiments in physiology with it. I was ambitious. I'm lazy now. I did it with my advanced students. Okay, because it was fun to do, and I could get a pass to do it. So what happens was that was a cumbersome tool. We used electronics. So we know the tidal volume, and then what happens is after that, obviously you're not moving just a half a liter. If you take a deep breath, you could take a considerable amount of additional air in, 2 to 3 liters. You can blow out about a third of that, maybe a liter. And even then, you can't completely empty your lungs. There's something called the residual volume. Mostly that is air that keeps the structures open but really doesn't contribute to respiration. And the whole idea is to determine how much air you have that's available to service oxygen and carbon dioxide exchange, and how effectively you can use it. That's what we're coming to. So we developed these capacities. By far and away, the significant one is this: vital capacity. Its name tells you that. Think of it this way: take the deepest breath you can and blow out as much of it as you can, as quickly as you can. That's what we call the FVC, forced vital capacity. It should be approximately 80% of your total lung volume. How do we measure that? There's a formula. You can go online. It has to do with your body, your size, your height, chest girth, age, a series of factors you would enter, and they can approximate this. So it's not like it's something that you couldn't calculate. And that's everything, including what your total capacity is likely to be, even including the quote unquote dead space, the so-called reserve volume. And it looks like this. So here's the tidal volume. When we take that, the usual in and out, and how much we have left to inhale, that's the inspiratory capacity, how much you could absolutely inhale. Roughly based on this, which is about 6 liters. And most folks, 5.5 to 6 liters is about right for the amount of air that you move out. It's based on what's called the minute volume, how much air you move out with every respiration. 500 milliliters, about 12 breaths per minute. Every minute you move about 6 liters. Most of us do. The other side of that is the expiratory reserve aspect of it. Tidal volume, how much you can get rid of. Collectively, you bring those two, you get the vital capacity, add what you're not using, total lung capacity. And they have roughly the numbers. And as you can see, other than the tidal volume, proportionately, women are, and it's a broad brush, obviously. And again, you have to do the calculation. But in general, maybe a little bit less, quarter to a third less in volumes, if you want to think of it that way. I mean, I don't make more of it than what it is. Dead space is interesting. That residual volume includes this, anatomical dead space. We always have to have a certain amount of air in there in the passageways. It doesn't contribute to oxygen and carbon dioxide. Depending on if you were like me and a smoker, if you had pneumonia, you may have more of it. And so there is unusable space. And sometimes it's just a certain amount of volume that you have in there that are there. We use these measurements to determine whether or not you have one or both of these disorders. These are chronic pulmonary disease, something you would not at your age, and unless you have something unusual physical. We classify them as either obstructive or restrictive. Obstructive means there's a blockage moving air in or out. Okay? Increased resistance, different kinds of bronchitis, a tumor, mechanical blockage, some malformation. All of these may increase because of hyperinflation of the lungs. That person with the obstruction is trying to suck air in, can't get it through the obstruction, and you end up with an increased amount of air creating dead space in the lungs. The air is trapped. The name we give to trapped air, emphysema. Emphysema is only about the lungs. Trapped. Restrictive, total lung capacity, a functional amount, disease, environment, toxins, smoking, etc. Disease entities like tuberculosis. Okay. So you can see all of these decline because you can't effectively use the lung. So it restricts the exchange versus impacts moving air in or out. We basically use the same measure to address those, and that's that forced vital capacity. So what happens is this. We look at the volume of that forced vital capacity, the amount of gas you can expel in a particular interval. The FEV1 means in 1 second, you should be able to expel roughly 80%, plus or minus 5%, of your forced vital capacity in the first second. If you can't, it's less than that. Under, let's say 75 would probably be the number I would use. Whereas those with restrictive disease exhale even more, surprisingly enough. With restrictive diseases, they have such a limited vital capacity, there's nothing obstructing it. It's just not that useful. It's there. So that FEV1 is the real measure for the obstructive diseases. The overall value of the vital capacity, if it's diminished significantly, that's the restrictive disease. And here's what they did, the minute volume or minute ventilation. And this is how it works. It's a great chart. Normally, you and I, effectively moving in, let's say, of that 500, we're averaging somewhere between, let's say, 15 to 20 breaths. 12 to 20 would probably be the range. Everybody's a little variation. Only 70% of that is useful because 150 is dead air. It's not dead unusable, but it occupies the space just to keep the tubes open. So your rate is 70%. When somebody's hyperventilating, double that, okay, 40 times a minute, they have the volume, the relationship between them. You still get the same total amount, but only 40% because only 100 milliliters of that 250 is useful. Whereas if you take slow, deep breaths, that's what you tell patients to do. Slow, deep breaths. You're optimizing the usable air while at the same time you're increasing the volume. You pump that number up to 85%. It's a good thing. And then the rest of this is just gases and gasless. I'll show you what the chart looks like without going, because I don't want to really go into all that other stuff. So I took a couple of screenshots. I did these yesterday. So here's your table. You can follow along. Now, in the classroom, it's difficult because it's hard for a student, and here's the setup. They're sitting, he's got a pair, you have to do it through the mouth. So you have like it looks like a cardboard cylinder, but you close your mouth completely around, you put a clamp on the nose, so it just goes in and out of your mouth. It's a little hard to get to, let's say, breathe relaxedly. So most of the time, when I look at the tidal volume for this individual, let's say that's from 0.6 down to roughly it's about a liter. It's typically a little larger. But when I asked him to do this, look at the extent, how rapidly, this is in a matter of a relatively short period of time. Okay, so if he started here and got up to here, that's surely 80%, easy. And blew out the better part of 4+ liters. Pretty good. So that was one individual. And then here, I'm trying to think of who's who. Yeah. Was this the same one? Yeah, that was the 4 liters. Let me do the other one. And this one was a little bit different. So, and I'll reduce the size of this just a little bit so you can see the scale. So here you're approaching 0. Maybe this was 7/10, 700 milliliters. And here's his, which is a little less, 2.6 way down here, 4. It's about the same. So if we looked at that interval there, you certainly could blow out the better part of 4 liters with that. That's really what you do. And I've seen these tests done. So we get a patient years ago. I had a patient with respiratory problems. I'd send them out and would say pulmonary function studies, also known as spirometry. You ask for it in the hospital, you ask for post-op spirometry. The respiratory people will come in with an incentive barometer. It's like blowing into something, try to get through walls, move up and down. They're doing that to try to get people using their lungs after anesthesia because they're very, very prone. So they do what's called sensitive. It's not the same thing. This is an actual test where you're looking at volumes under specific conditions, rather than trying to just make people, every hour do some breathing stuff so they can move stuff out and hopefully bring up some mucus stuff to avoid having pneumonia, or as we like to call it, pneumonia. That way I don't mess up the spelling. It's supposed to be funny. Oh, you're not good. And that's really what I have to share with you, more or less, about lung stuff. The rest of this and it talks a little bit, let's say, let me just back up a little bit here. So the membrane is very, very thin. It's a sandwich of two squamous cells with a thin piece of membrane. It's like just a little piece between there. So the air can move, the oxygen and carbon dioxide. It's got a ton of surface area. Your lungs, 40 times your total skin. You got a lot of skin. For you nurses, forever, nursing tests love, because they see so many lung patients. They love a condition. We don't even use the term anymore. It's called core pulmonality. Core for heart, pulmonality for lung. So what it is effectively is a kind of right heart failure. The lungs don't work, okay? And what happens is, okay, pneumonia or left heart failure pushes it back into the lung, and then the right heart enlarges, can't push into the lung to get blood reoxygenated. So they take a lot more time to go through, and they aren't sufficiently oxygenated. Remember, core pulmonality usually is a term associated with some defect in the lung, whatever its origin is, that doesn't allow the right heart to efficiently. So it's like, ultimately it's a plumbing backs up. That's what I look at. I look at these things when we get to digestive and urinary plumbing problems. What happens if they back up and there's blockage? I think I try to, look at it that way to understand how it's happening. Emphysema, that's when we get the trapped air. The walls break down from damage, let's say from smoking, and the chambers enlarge. They fill with a bunch of yucky stuff. That's an actual micrograph at the same magnification. It's not bone. It looks like bone trabeculi. That's surface area for carbon dioxide and oxygen exchange. Look at those big SWAT. Notice how this is thicker compared to that, denser. And notice how much air. That's the trapped air. Emphysema, trapped. In micro, with me, for those that unfortunately have me, we'll learn about subcutaneous emphysema, which is what was the hallmark of the flesh-eating bacteria, necrotizing fasciitis, neck fash, as we call it in the trade. And these are important terms: ventilation, oxygen and carbon dioxide in and out. Perfusion. We want organs to be perfused. That means they have an adequate amount of blood supply. And I was mentioning this to one of the students before. Oxygen controls the arterioles so they can go to areas where the oxygen is needed. The CO2 changes the bronchial diameter so we can expel the CO2. Those are these adaptive things that all organs have it. The lungs particularly. And I said this to you before. People can be breathing normally, and all of a sudden they have to be on oxygen for the rest of their life. I mean, I was heading there. Okay? It'll be 15 years I haven't had a cigarette. I haven't smoked anything for 15 years. On June 20th, which would have been my parents', what year is this? 70th anniversary. No, 80th anniversary. 80th. 1943, during the war. If I add up my marriages, I'm getting close. You got to add. So I've been more or less, from 70, what is that? So that's 45 years. I've been married for, like 40 of those. Not the same person. And not simultaneously to more than one. Really. Scout's honor. What's wrong with that? Okay, enough of me listening to that. Moving on to digestive, my favorite topic. I brought in a chunk of our homemade lasagna weekend for lunch. It's yummy. If you want to make it easy on yourself, get Rayo's sauce. You don't have to go through the make the sauce thing. Get the Rayo's marinara. I know it's expensive. No fault. No fault. Just saying. Guys just are no fun. Digestive. Here we are. Okay. There's a lot of anatomy and a lot of physiology. It's a complicated system. It's the oddball for one reason, because what digestion is. When we digest something, it's really two things. People erroneously use the term digestion for, oh, you got the food, you ate it, you processed it, and you absorbed it. That's digestion is just one factor in that. We use the term digestion to reflect digestion and absorption. It's not the case. That's there. So it's somewhat, we understand it, but it's somewhat, a contradiction in terms, if you will. And the beauty of this is anatomically, it's different because of that. We have a dedicated area that's modified. Everything we looked at blood vessels, lining, simple squamous, nice and smooth so things flow evenly. Heart, blood vessels. We looked at respiratory, pseudostratified ciliated columnar with goblet cells for mucus to trap particles and so that we can expel them. Here, the hallmark epithelia is also goblet cells, but simple columnar because we replace them so easily that are there. So it differs in that regard. But rather than having just a lining of simple squamous or stratified squamous or pseudostratified ciliated columnar, we have a very complex lining that's designed for enhancing digestion and facilitating absorption and dealing with the problems that are associated with it. It's very unique. Most everything has threes. Blood vessels, you have the externa, the media, and the intima. The eye, we have threes, right? When we get to the urinary, we have threes. Respiratory, we have three layers. Digestive, we got four. Coming up. I love that. So what does it basically do? We ingest. That's taking it in. We break it down. That's digest. You're going to see that digestion, even though I don't love the terminology in this textbook, and I haven't loved it for 20 years or more that I've been using it, okay, there's mechanical digestion, which is more than just chewing something, and chemical digestion. They both contribute, and they occur very often at the same time, but are often highlighted in certain areas. The stomach, even though there's chemicals in it and it does chemical digestion, is mostly mechanical. It's a mixing bag. Okay? The small intestine, certainly there's mechanical aspects of it, but by and large, it's mostly chemically based. That's breaking it down into the fine particles that you and I can absorb more easily. And that's absorption. It doesn't just bring the molecules into the bloodstream, because a lot of those molecules go by way of the lymph. Lymph is something you should have covered with vis-a-vis immune system. Lymph is where infections and things, bacteria and viruses frequently travel, cancer cells travel. Also, heavier products and fatty products typically travel. So the absorption is a very interesting composition, something you're going to learn about. It's called a villus, or a finger-like area that has a capillary surrounding what's called a lacteal, which is the lymphatic structure, which is one of the hallmarks of it. Love that. So that's ingestion, digestion, absorption, and obviously elimination. So we get rid and understand what we eliminate is not just undigested food. That's a basic misconception. Okay? Our elimination process works even if we're not eating solids. Okay? Feces, okay, consists of roughly in equal parts undigested food, cells. There's no area in your body where you shed more cells than this on a daily basis, and water, about equal parts. How is it classified? Our part anatomically? The alimentary canal. The alimentary canal is a hollow tube that goes through you. It's not in your body, it's just going through your body. My favorite analogy for that is a spool of thread. Okay? Where the spool is, where you put it on the sewing machine, that opening, that's your alimentary canal. You, inside of you, is the thread. If it's wrapped in something, think of it as the skin if you want. Okay? That's how it works. So when you get food poisoning, it's not necessary that the toxin has to go inside of you, though it could. Okay, sometimes it's just enough to damage the lining on the passageway to create problems that are associated with it. That's the most common kind of food poisoning that we get. Something called food infection is where those toxins or elements goes in you and can cause more widespread damage. That's something that put me in 2006 in intensive care in a near-death environment. They don't put you in intensive care unless you're close. I told you that already? 2006. My mom at the time was 87 years old. They put me on a Friday. That night they called her, my 87-year-old mom, to tell her I was close. Close to my expiration date. My best buy date was coming to an end. I had sell by, I showed them. Okay, so it's a continuous muscular tube, smooth muscle mostly, that runs from your mouth to your anus. Goes to outer space. I'm really unhappy. No response. Digestion, absorption. What are the structures? It's a tube. There's just variation, shape, certain appendages like teeth in your mouth. The pharynx, shared system with respiratory. The esophagus, when that pharynx divides, we have the trachea for respiratory. We have the esophagus, stomach, small intestine. These are continuations. Large intestine, they've just varied in shape. And then finally, exit point. Anything else, teeth, tongue, gallbladder, liver, pancreas, salivary glands, all are accessory structures. You're going to see a similar pattern in the reproductive system. We have primary organs, ovaries and testes. Everything else is an accessory structure. We have the kidney as the primary structure in the urinary system. The urinary tract, the ureters, the bladder, and the urethra are just really the route out, the exit. So voila, it's not how measure the distance between your torso and your mouth. What is that for most of us? At most, maybe 3 feet. Yet there's about 30 feet of stuff in here. So it is amazingly folded on itself and compacted into an area that you can get 30 feet of tubing into this area, exclusive of the 4 pounds of liver that are in there as well. So again, the liver is accessory, the pancreas, little under there, very interesting gland. The gallbladder, really just a storage sac for bilirubin. It's along the line of what we call non-essential structures. And you have all this. And interestingly enough, the largest of these, not by length, but by size, the colon or large intestine, probably about 8 feet going up, across, down, and then finally out, is non-essential. We don't need it. A very long girl I first dated when I was in high school, and she lives out in California, so we've talked a couple of times. In the last X number of years, wherever long that was, 50 plus years. Ended up having to remove all of her colon because she had ulcerative colitis, a very nasty autoimmune disease. Had to have that done. I haven't spoken with her since, so I don't know. More than 10 years. So here they are. Ingestion, movement, very important. This is principally a smooth muscle system. How does it get there? The most amazing thing, peristalsis. The beautiful thing about the digestive process is that by and large it governs itself. It has the remarkable ability to work on mostly stretch receptors. It's a tube. When food enters, it stretches. What do muscles do when they're stretched? They respond reflexly by contracting. Peristalsis is food enters, the muscle contracts and pushes the food along. So it squeezes it, and pushes it. I'm thinking toothpaste tube at the bottom. You know, you got that last bit of like ointment that you have to get out, like for Neosporin or something like that. I gotta get that out. That's peristalsis. Food that involves alternating waves of contraction and relaxation. If it was all contracted, it wouldn't move at all. So it contracts and relaxes, etc. Looks like this: squeezes, pushes, then relaxed here, squeezes, pushes. We're going to get to a variation of that in the intestinal area called segmentation. It's not just unidirectional. There's a certain amount of over and back. That facilitates maximum processing. So we see that in the intestines. So it's basically moving from segment to segment back and forth. So it's maximally processed. Love that. And it does this without any other controls. It has its own nervous system that governs what it does on the inside. You and I do not have to superimpose ourselves in us. The main nerve that supplies this system is the vagus nerve. I don't have one going to my stomach. They've taken a piece of it out on not one, but two occasions. Yet, I'm still able to eat. My wife would tell you to excess. Yeah. Believe me, over the weekend I was staying where the dog was staying. So we like to say it in the doghouse. I didn't have to eat the biscuits though. We get a great biscuits from Sam's Club. 5 ingredients, peanut butter. I would eat it. It's good. I'm willing. Hey, if it's got you put peanut butter on a bumper, I can try to eat it. I love peanut butter. So they call it mechanical breakdown. So I call mechanical digestion. Segment, all that movement I was showing you, mechanical. Okay. Digestion, I call that chemical digestion. Steps that break down complex molecules. Absorption, GI tract, blood and lymph appropriately. Defecation, getting rid of what's left. Good chart for reference when you get to this unit, if you have not started it as yet in lecture, where it kind of tells you what's going on. We're mechanical, we have a lot in the mouth, limited chemical, not a whole lot other than moving it along in the esophagus, mostly mechanical in the stomach, some chemical. Nearly everywhere else, it's almost all chemical and limited mechanical other than pushing it along. It's very interesting. So our purpose is the organizational table that's associated with it, which you're going to find interesting, I think. I don't have a model that I could show you. I mean, we have all these things up here. It's not that easy. What's interesting, normally when we look at the lung, you got this, when we look at the heart, you have 2 layers of lining with fluid. You have pericardium, visceral on the organ itself, and parietal on the wall. On the lung, visceral on the lung itself, parietal on the wall. It's different. You have peritoneum. Yes, you have on the wall, you have parietal peritoneum, the abdominal. But viscerally, you have a very unique layer of peritoneum. It's kind of like a sandwich. So you have the peritoneum is folded, and inside the folds, it's got stuff, blood vessels, nerves, lymphatic tissue. And they are designed they're the passageway for nutrients, life support, if you will, going to all the stomach, the large intestine. So it's called visceral peritoneum. The combination of the visceral peritoneum and the structures that are in it, blood vessels, nerves, lymphatics, etc., immunological tissue, all of that, we call them mesentery. And there's even more of it because you have a special piece that sort of anchors the liver to the anterior abdominal wall. It's a very complicated journey on the inside. But that makes it so interesting. And really what it does more than that, it anchors not just the liver that holds it. So I always share this anecdote. I was doing my first year of residency, and I was doing a rotation in, I don't know if it was the ER that night or the OR. I was probably tagging along the emergency. And all of a sudden, we had a guy came in who got shot or stabbed. And, and so they took him up to an exploratory. It's called the Black Rock, he goes himself. Okay. And we're inside, and they're, you know, and it's amazing, this guy had either shot or stabbed, didn't have a lot of ammo. So he had little nick, I saw a nick in the valve, I sewed it up, we surgery doing it. All I'm doing is 2 hours long. That's my sweaty balls that I don't, hard the expression, yeah. Well, you're tired. So he's doing this. Oh, we have a little heater in the neck. He goes, oh, this is good, but I'm going to run the valve and we're going to close. I'm like, great, that's hard. I didn't say that. That's why I was thinking behind the fence. And he proceeds. Here's the valve. Here's what they do when they run the valve. He's taking out the intestines, mostly small, some large, and he's doing this. He's looking to make sure that he didn't miss any major cuts. Out. He ran it all the way in one direction. He ran it all like that. Now, at that point, outside of this incision here, you have all this valve sitting on the sterile field. And I figured then he was going to open it up, with it, just shoved it back in. You must see my eyes. He goes, oh, don't worry. The mesentery hasn't, it always goes right back to the position. I was astounded. Absolutely. This guy was up walking the next day. And I got news for you, that wasn't his first time he could eat a shot or something. He had a guy, 14 stab wounds. He didn't have electronic fitness. This is old, a long time. He had a check day, a welfare check day, first of the month. They would go to the welfare office to get their check. People would rob them. That's how this for drugs. This guy had a big coat on this. He had 14 months. That's why for doctors and when you work under those conditions, it's extraordinarily stressful. You get a tremendous amount of learning, and you only can do it for a limited amount of time because you kind of get burnt out. So I'll show you the pictures about this. And obviously the fluid and the peritoneum, the mesentery, double layer, fused, all the stuff that's in there, holds it in place, the point I'm making. So we call that intraperitoneal. Sometimes it's a system that's constantly moving. It's designed to move. The worst thing that can happen is if it doesn't move. There's a couple of areas for stability where this mesentery, to some extent, has been reabsorbed into the back wall. We have a name for that, retroperitoneal. So your kidneys are retroperitoneal. The duodenum is one of the parts. A couple of parts of the colon are retroperitoneal. Think of them as stability points so that the rest of the unit can function. And the worst thing that happens with abdominal surgery or general surgery is something called adhesions, and it's just that, where it adheres to itself, and therefore it can't move freely. And that's the kind of thing where you have to go back in and try to do something about it. Here we go about me again. I know. I have survived two, not one, but two giant abdominal surgeries, one in 1993 and one in 2000. 8-hour surgeries for ulcers, okay, where they had to remove half my stomach and reroute the stomach into the small intestine. Not once, but twice. Okay, so it ain't easy, and it's a lot. It took me a lot of time to recover from that. Fortunately, my stomach re-expanded. It's different when you have people have stomach surgeries. They lose weight, they cinch it, and now they do it differently. But they cinch it so the stomach can't re-expand. So mine didn't get the memo. When's lunch? Here's what it looks like. So there's the mesentery. This is the liver. You can see is anterior, more mesentery. This is retroperitoneal. So you understand it. When something, it's a sterile cavity. If something bursts, appendix most commonly, uh, rupture from the genitourinary, like an ovary, a tube, like a tubal pregnancy, cancers, then all this stuff, because those linings are covered with bacteria that get into the area. We call it gram-negative sepsis. And that's something that I addressed with the micro students a little bit. I'll leave, this would be the last part. This is maybe the most complex part. I don't want to overwhelm you today. Okay. There are 4 layers. Normally, we just have a mucosa layer, the lining that does the function. We have muscle, typically smooth muscle in a hollow tube, like a blood vessel, only something on the outside. And this, like we call, in this case, it's the same thing. We call it serosa because it's moist and it can slide over one another. But we have 4 here, and it's not so simple. Okay, the mucosa is the innermost layer, the hollow tube, which facing into the tube. It has 3 different parts of it. It has a lining, simple columnar with goblet cells. This starts at the stomach. It has what's called a lamina propria. That's a specialized underlaying bit of connective tissue that has blood vessels and nerve endings and lymphatics, because that's really the contact point with stuff coming in from your small intestine and or your large intestine or stomach. And then underneath that, yet another layer called a muscularis mucosa, a special layer of smooth muscle that's designed to facilitate the process of digestion. The lining, simple columnar. The mouth, where the food is not yet being processed and is still kind of rough, stratified squamous non-keratinizing. When it's exiting, same thing. Mucus to lubricate it and protect it, slides along, maybe some, and we're going to go into the different enzymes and stuff. Lamina propria, underlying all epithelia are luciolar. A lot of blood supply here, a lot going on, particularly a lot of this. You see this in respiratory, you see it in skin. It's called MALT, mucosa associated lymphoid tissue. In the gut, it's actually called GALT for gut or GI associated lymphoid tissue. Wherever we encounter the outside, you've got to have a lot of lymphatic structures to deal with. It's a likely sort of invasion. I mean, anybody here not have some type of foodborne illness? The quote stomach flu that really doesn't exist? We've all had it. And the muscularis mucosa. That's what it looks like. So you have the lining. What you're going to see down the road, we're going to get into the next time, just is you end up with these openings that are very specialized and form what are called, the opening is called a pit. And then at the bottom, it has a gland that's located way past that muscular layer. So, and the small intestines are called crypts. They differ slightly, but they're similar. So this is the way that secretions of fluids and chemicals assist. The lining is there to replace yearly in totality, every 3 to 6 days. Every month, they're constantly exposed to food. They're constantly busy. They're constantly exposed to chemicals and behaviors, and they're constantly being replaced. In the submucosa supports that lining. It has lymphatic tissue. Some of the glandular structures penetrate into that. And then you have this specialized layer called the muscularis mucosa. It's designed so that when food, so here's the tube, when food enters it, it senses that by pressure receptors and it forms to the food, maximizes contact. I like to think of it as embracing. It's a romantic notion. It's a wonderful piece of lasagna. I can imagine my gut saying, well, we're having lasagna, I'm so happy. Okay. Come on. Supposed to give you pleasure. The fact that you're too skinny. Uh, I demand a recount. My two cousins on my dad's side, one's deceased now, are like 6'3" and skinny. What happened? I don't like that. Could have been a contender. So that's the muscularis. Then you have the submucosa that's dedicated to supporting this elaborate structure here. So normally you have under a lining, you have a relatively simple layer. Here, the submucosa has its own nerve endings. It has its own nerve complex because you don't need external nerves to make the system work. And then you have consistently throughout, with some modifications, layers of smooth muscle. This is what makes peristalsis work. You have an inner circular, so you have that tube, you have circular muscle around it, and then longitudinal muscle outside of the circular. Squeeze with the circular, push with the longitudinal. It facilitates peristalsis. It too has its own what's called myenteric nerve plexus. So you don't need external controls. It's preset. Your autonomic nervous system, the parasympathetic, set the tone. The only thing that really alters it, maybe you have an increased degree of parasympathetic when you're relaxing, because that's when it's busiest. And fight or flight, the sympathetic takes over and stops it, because it's diverting blood elsewhere. And then lastly, you have the outer layer, typically and surrounded by mesentery, called serosa, which is moist because those structures have to slide over one another. So submucosa, areolar connective tissue, blood and lymphatics, more lymph tissue, nerve plexes, elastic tissue. So even if you eat a lot and it's distended, whether it's the stomach or the intestines, they come back into shape. Segmentation and peristalsis, inner circular, outer longitudinal. Thickenings of this external layer make sphincters. We'll get into those next time. And lastly, the serosa. Again, areolar connective tissue covered with mesothelium, squamous epithelium. In some areas where it's not designed to move, like the esophagus, we call it adventitia. Retroperitoneal organs have a little bit of both. And we'll call it quits there. If you want me to open that up and squeeze it, we can squeeze it. If not, don't worry about it. Thank you very much.